This is Dr. Howard Strassler presenting the e-lecture Decision Making and Restorative Interventions, Class 5 Cervical Lesions, Module A Non-Carious Cervical Lesions, NCCLs. When we look at the classification of non-carious loss of tooth structure, including cervical loss of tooth structure and incisal and occlusal loss of tooth structure, they really fall into four main categories: abrasion, attrition, erosion, and abfraction. In fact, in most cases, the loss of this tooth substance is multifactorial. Let's look at the definition of these different non-carious lesions that are related to loss of tooth structure. First, there's abfraction. Abfraction refers to stress corrosion of the cervical enamel margin of the tooth caused by non-axial forces on the incisal, occlusal, and palatal surfaces of the tooth, placing the hard tissue in tension and then compression. In fact, at the CEJ, cemento-enamel junction, that flexure causes enamel to be lost, enamel to microfracture, and this is referred to as stress corrosion. Abrasion is the loss of tooth substance due to mechanical means, such as brushing, toothbrushing with an abrasive paste. We might see abrasion as it relates to a patient eating a very abrasive food, and that food is causing loss of tooth structure. Attrition refers to loss of tooth structure caused by wear. Wear due to bruxism, due to clenching, parafunctional habits, and attrition is generally seen on incisal edges and occlusal surfaces. Erosion refers to loss of tooth structure by chemical processes, typically acid erosion of the tooth, due to foods and beverages that are acidic that we eat and drink. And then erosion leaves the enamel rods and dentin softer, and when we brush with a toothpaste, we're now going to abrade it off. On the occlusal surface, normal function and parafunction, bruxing and clenching, can cause an accelerated loss of tooth structure with erosion. In fact, that would be erosion with attrition. When we see a patient brushing away softened enamel, softened dentin, that's a combination of both chemical erosion and abrasion. We're going to be focusing in on clinical perspectives of the Class 5 non-carious cervical lesions. Patients know it as root notching. They can feel it with the fingernail of their finger. When they smile, they can see that as the enamel crown ends right around the gingival line, there's a notch of the tooth. And we can classify these non-carious cervical lesions on enamel and dentin on root surfaces as abfraction, erosion, and abrasion. Here we're looking at some clinical examples of these non-carious cervical lesions. On the right-hand side, we can see lesions on the maxillary lateral incisor, number 10, and on tooth number 12 at the cervical, where we see these somewhat saucer-shaped lesions. On the mandibular incisors, we'll notice that there's a more angular in shape lesion, and these are typically indicative of abfraction-initiated, stress corrosion-initiated lesions. Now, when we take a look at these non-carious cervical lesions and we look at the three different classifications, I want you to notice that there's an arrow connecting all three of these systems. And the reason there's an arrow is that this equilibrium of loss of tooth structure is really multifactorial. It's not one or the other. There's no pure lesion. In fact, what characterizes abfraction, erosion, and abrasion is these lesions may be sensitive or not sensitive. They may be shallow or they may be deep, and in fact those categorizations help us determine what interventions we're going to recommend to the patient, what are we going to treatment plan for these lesions on the facial and lingual surfaces. Here we're looking at a Class 5 abstraction lesion, a cervical non-carious lesion, and this one's on the facial surface, and it's initiated by the occlusal forces causing flexing at the neck of the tooth. Heavy occlusion contributed to this very angular deep lesion. When we look for abstraction as to how we're going to intervene, that once again we categorize these as being not sensitive or sensitive, and then categorize them further as being shallow and deep. And from this flowchart you can see that we have interventions based upon the clinical conditions and the clinical signs and symptoms that we see. We'll talk about this in detail. In fact, whether it's an abstraction, an erosion, chemical erosion, or an abrasion, there's a commonality in the way we treat these lesions and how we treatment plan them. Well, with the diagnosis of abstraction in a tooth that's non-sensitive, for the shallow lesion, and that would be a lesion less than 1 millimeter in depth, less than 2 millimeters in gingival incisal or occlusal and gingival height. And these shallow lesions may have no treatment at all. We may decide to do reevaluation, active surveillance, and follow this lesion over time. As these lesions get deeper, and we're talking about depths of 1 millimeter deep and 2 millimeters in height, which can easily be measured with a periodontal probe, we're going to consider a restorative intervention with either composite resin or glass ionomer. Since abstraction lesions are teeth that are flexing upon the root, we're going to also evaluate an occlusion, consider an occlusal guard, or in some cases where there's malocclusion, we may consider a limited occlusal adjustment or a complete occlusal adjustment. When these lesions are sensitive, in many cases, the patient self-diagnoses the presence of these lesions. We generally see root recession, gingival recession on the root. And for the shallow lesion, because of the sensitivity, we'll consider using a desensitizing toothpaste. In Module D of this series on Class 5s, we'll be speaking more about desensitization, toothpaste, the active ingredients, and the treatments to desensitize. Besides recommending a desensitizing toothpaste, we might recommend a desensitizing agent that we apply in office. And we'll talk a bit about them in Module D of this series on the Class 5. For deep restorations, once again, greater than 1 millimeter in depth and 2 millimeters in gingival incisal or gingival occlusal height, we'll consider a restoration with composite resin or glass ionomer. Once again, these are stress corrosion lesions that we're looking at evaluating the occlusion and making recommendations for treatment based upon the wear attrition on the occlusal surfaces and the incisal edges. The Class 5 chemical erosive lesion is a cervical non-carious lesion, typically seen on the facial but can be seen on the lingual, and it's initiated by chemical softening of the root surfaces on the cementum and dentin. And it's in combination with the presence of gingival recession, so the root surfaces are exposed. Usually the initiation of this lesion is an acid attack of the tooth surface. This acid attack can come from several different sources to include ingestion of food, ingestion of high acid beverages such as energy sports drinks, coffee, iced tea with a lot of lemon in it, and certainly soft drinks. We might also see acid attack not on the facial but the lingual surface from GERD, gastroesophageal reflux disease, where the patient is bringing up hydrochloric acid from the stomach acid dissolving the enamel, and then in normal function, regular eating, and with brushing with a toothpaste, we're going to see loss of tooth substance. A chemical erosive lesion is typically noted as being saucer-shaped and rounded, as we can see in the clinical picture that's being portrayed here of the maxillary anterior teeth. In fact, this patient is softening, dissolving, demineralizing their enamel because they have a history of placing and sucking on lemons in their upper lip. You will see many very odd habits, oral habits, that can have consequences on oral health, the appearance of tooth structure, and how tooth structure survives. The decision-making for the chemical erosive lesion is very similar as for the abfraction. Where no sensitivity is present, no root sensitivity, no dentinal hypersensitivity, in the shallow lesion there's no treatment. We'll do active surveillance and reevaluate that. As we see a deeper lesion, 1 millimeter in depth, 2 millimeters in height, our consideration is to restore with an adhesive composite resin or an adhesive glass ionomer. Key, though, to our recommendations is that we're going to talk with the patient and evaluate and recommending changes in their acidic diet, consideration to a low abrasive toothpaste, and changing their brushing habits. We'll talk a bit more about that in a few minutes. When a patient has a class 5 erosive chemical erosive lesion, and the teeth are sensitive, many times it's self-reported by the patient. They'll tell you, I drink something cold or I breathe in air and my teeth hurt. The pain goes away within a few seconds, but it's very uncomfortable. And for patients who have sensitive teeth with shallow lesions, usually combined with gingival recession, just as with the abfraction lesion, we consider desensitizing the teeth either by prescribing for the patient over-the-counter toothpaste that are sensitivity toothpaste, or applying a desensitizing agent intraorally. As the lesions get deeper, our consideration is a restoration with composite resin or glass ionomer. Once again, as part of our recommendations, we're going to recommend changes in diet, a low abrasivity toothpaste, and changes in the brushing habits, from a hand brush perhaps to a rotary mechanical brush. So we talked about it being chemical softening. We talked about the diet having a major impact upon dental erosion. We need to identify the etiologic agents by asking the patient to keep a food diary, and a very specific food diary. The patient will need to write down everything they ingest in their mouth, from beverages to food, not to leave anything out. To write down in that food diary when they ingest that food, what time of day. And this will give us an idea as to what's going on. We need to identify acidic foods and beverages, or acidic sucking candies that have citric acid. Those beverages may include energy drinks, sports drinks, that may include sodas, soda pop. It may also include the presence of fruit juices, acidic fruit juices, orange juice, grapefruit, among them. These all can have negative impacts upon the teeth and cause acid erosion. We're also going to look at the patient's oral hygiene habits. If they're doing long strokes, we may change them to a short sweeping stroke towards the sulcus. We may move them from a hand brush to a mechanical brush, so they're doing one tooth at a time when cleaning, and then a recommendation to a low abrasion toothpaste. Toothpaste can be characterized in their abrasivity by what's called the RDA number for a toothpaste. RDA refers to radioactive dentin abrasivity. Some people tell you it's relative dentin abrasivity, but in fact it's radioactive dentin abrasivity, where they measure the abrasiveness of a toothpaste on dentin, on root surfaces, with a mechanical system. And as they're brushing the teeth with the toothpaste, they're shooting it through a proton beam, and they're measuring the radioactivity in the slurry that comes off from the toothbrushing. The class 5 mechanical abrasion lesion is once again a cervical non-carious lesion, facial lingual, although typically facial, that's initiated by a combination of chemical softening of the root surface, that dentin and cementum surface, when the patient has gingival recession, and that this continues to see a loss of tooth structure due to brushing habits and the type of toothpaste that's being used. Abrasion is always associated with chemical erosion, with dental erosion. Its clinical appearance, as you can see here, is generally rounded and saucer-shaped. Okay, once again, this is multifactorial. It's a combination of the abrasion with the toothpaste and toothbrush, combined with the fact that the teeth, the enamel and dentin, are chemically softened, demineralized, microscopically dissolved by the acidic foods and beverages and habits that a patient has. One of the things I want you to notice about this clinical image is when we look at this maxillary canine, notice that there's gingival recession on the facial surface. The evidence is very clear from literature and research that's been done that loss of tooth surfaces and abrasion is a phenomenon of brushing with toothpaste. If we were to brush with no toothpaste at all, we wouldn't see loss of tooth substance, but we would see gingival recession. Toothbrushing with a toothbrush is associated with gingival recession. Abrasion, erosion, combination of them is associated with brushing with an abrasive containing toothpaste. When we look at these abrasion lesions, we look at the patient's toothbrushing habits, what toothpaste they're using. As we described for erosion and for abfraction, when the teeth are not sensitive and the lesions are shallow, we'll do no treatment. We'll do active surveillance. We will modify brushing habits and reevaluate. We'll make recommendations to the brushes used. We'll make recommendations to the toothpaste used. In deeper lesions, 1 millimeter deep, 2 millimeters in height, we're going to consider restoration with composite resin and glass ionomer. Once again, as we did with dental erosion, we're evaluating and recommending changes in acidic diet, low abrasive toothpaste, and brushing habits. When we see the abrasion and now the teeth are sensitive, whether they be shallow or deep, we're going to be more aggressive in what we're recommending. Besides changing a toothpaste to a desensitizing toothpaste, we may consider using a desensitizing agent. We may modify patients' brushing habits, going to a mechanical toothbrush instead of long, broad strokes, strokes with a rotary toothbrush. For the deeper lesions, we're intervening with restoration using a composite and glass ionomer. And when teeth are sensitive, whether it be abfraction, erosion, or abrasion, we absolutely are also going to recommend a desensitizing toothpaste. For teeth that are severely sensitive, even in the deep or shallow area, when we're doing a restoration, we're going to consider an in-office desensitizing agent treatment. And so we're making very strong recommendations. We're making recommendations about toothbrushing habits because those toothbrushing habits usually have an erosion, dental erosion component. Our dietary evaluation, as we would with dental erosion, is very key. We're going to look at a food diary to identify etiologic agents. We're going to identify acidic foods, beverages, sucking candies. We're going to look at their hygiene habits. Are the brushing strokes broad or short? Are they using a mechanical toothbrush or hand brushing? What toothpaste are they using? In fact, we're going to guide them to a toothpaste with low abrasivity. And surprisingly, many of the current whitening toothpastes have low abrasivity. I'm not talking about smoker's toothpaste like Pearl Drops or Topo toothpaste, which is a stain-removing toothpaste. I'm speaking to toothpaste that are not very abrasive, that are out there as whitening toothpaste. In fact, they may have the ADA seal of acceptance as being a whitening toothpaste. Making the claim that you're a whitening toothpaste is not a therapeutic claim, but rather a cosmetic claim. Let's take a look at some lesions. Here we're looking at lesions that are abrasion lesions. They may have an abfraction component because of their angular nature. How do we make the decision to restore with aesthetic materials? Well, we talked about the depth being one of the primary considerations, but also if the patient notices that there's notching on their tooth surface, they're going to want it restored aesthetically. Keep in mind, for many class 5s that are in non-aesthetic zones, it's absolutely appropriate to use an amalgam restoration. But as we move into the anterior aesthetic zone where one can see the patient's teeth, one can see the cervical third, our consideration is towards aesthetic restorative materials that are adhesive. What are our choices for aesthetic materials for class 5s? And this would be class 5s both that have caries or are non-carious cervical lesions. Well, one of our choices is a resin-modified glass ionomer. Resin-modified glass ionomers, and the material we use at University of Maryland is Fuji2 LC for light cure. It has adhesion by chemical bond. It is an acid-base reaction. There is some resin, 10% resin in the resin-modified glass ionomer. And we apply it to the tooth. The chemical bond, the adhesion, is an ionic interaction between the calcium and the glass ionomer, and it chelates the calcium. When you have a root surface that has cervical sensitivity, dentinal sensitivity, it's a better choice for restoration. Rather than using an acid etch and possibly opening up tubules, making the tooth more sensitive if we don't seal them, the glass ionomer doesn't require an acid etch technique. On the downside, our glass ionomers are less aesthetic than our composite resins. We don't have the broad range of selection with tooth shades, nor do we have a translucent material. Glass ionomers tend to be much more opaque looking. We find that glass ionomers are a better choice for patients with caries, especially due to systemic conditions like xerostomia, due to Sjögren's syndrome, radiation to the oral region causing xerostomia, or drug-induced xerostomia. Currently, there are over 100 medications that patients take that can contribute to dry mouth. Glass ionomers have the additional benefit of fluoride release, and they're protective. They reduce the recurrence of decay around margins of teeth. In fact, we can measure the fluoride coming off the glass ionomer in a zone peripheral from the cavo surface margins. Not only do we see fluoride release, but as we see the release of fluoride and the decrease in the amount of fluoride in the glass ionomer restorative, by the simple act of brushing with a fluoride-containing toothpaste or using a fluoride mouth rinse, we'll see that fluoride recharge itself to the glass ionomer surface. We also, for class 5 with aesthetic materials, whether it be caries or a non-carious cervical lesion, we can use a composite. Composites are placed with a minimally invasive design through adhesive bonding via micromechanical locking to the etched enamel and the etched dentin. It's our most aesthetic direct restorative material, far more aesthetic than glass ionomer. One problem, though, is when we're acid etching, we can cause an increase in root hypersensitivity. So for these cases, glass ionomer may be a better choice for patients with broad areas of dentinal sensitivity on the root surface. Composites are more wear resistant. They're more wear resistant to chemical erosion than glass ionomer. In fact, acidic foods that we ingest, acidic beverages that we drink, can cause a glass ionomer to lose surface and chemically erode. Patients who have root caries and class 5 enamel caries due to poor oral hygiene, let me repeat that. You see root caries, you see enamel caries in the class 5 in the cervical region. That the reason the patient has caries is their lesions of neglect. The patient isn't brushing their teeth well, the plaque's maintaining itself, the patient has a high diet, in sugars to feed that plaque. We need to change those patients' habits. We need to educate them as to how to be a co-therapist to partner with us and help keep the teeth clean. When we see that change in habit in what they're doing and how they maintain their mouth, for those circumstances, composite's a better choice for restoration. Okay, root caries, class 5 enamel caries, and what we're seeing is the patient changes their habits, the bacteria is under control, the bacterial infection is under control, and we can restore those teeth with composite. That's different from when the patient has a systemic condition leading to dry mouth, to xerostomia, and that we see at-risk areas at the cervical, and we see that they're at risk because we see the initiation of root softening, we see the initiation of demineralization, and the initial carious lesion on the cervical third. For those patients with dry mouth, with drug-induced xerostomia, with medical conditions that contribute to dry mouth, use of glass ionomer to prevent recurrent decay is a better choice. How do we evaluate the progression of this non-carious class 5 lesion? Well, first off, we can chart the depth and height of the lesion using our periodontal probe, making a note as to how deep it is in its deepest region, and what's the occlusal gingival and incisal gingival height of this class 5 non-carious cervical lesion. We can make an impression of the tooth that has the lesion. We can track changes with a subsequent impression and cast a year later. So we'll make an impression capturing in detail that cervical lesion. We'll pour it up as a cast and store that cast in a patient's storage box, in their case box. A year later, we repeat the impression. We've made a note in the chart to remind us on the 1-year recall to repeat the impression, and that will help us make a judgment whether this is an acute loss of tooth structure or is it a chronic lesion that had its acute stages many years ago, but it has it has an equilibrium and is not continuing. In some cases, we may see non-carious lesions become carious. When we see that, we become much more suspicious of changes in diet, having a more highly sugared diet, changes in oral hygiene habits, changes in salivary flow. When we're doing preparations for these class 5 non-carious cervical lesions, we're going to use an enamel bevel of 1/2 to 1 millimeter in length and 1/2 the thickness of the enamel. We're on the root surface, and on the root surface itself we leave a right angle margin. As these lesions get deeper into the dent and onto the root surface, our enamel bevel will be the same. Our cervical cavus surface margin at the gingival will be the same too at right angles, but our consideration is to the placement of a notch, a retentive area created with a quarter round burr. Keep in mind in these abfracted lesions, these teeth that have abfraction, that these teeth are flexing and the composite may in fact, or glass ionomer, pop out, and this cervical retentive area helps in their retention. So let's take a look at a case. Look at the non-carious cervical lesion, a combination of abfraction, erosion, and abrasion, especially in the second premolar and first premolar. Canine probably is more of a chemical erosive situation. I want you to notice that there's a class 3 malocclusion. In fact, these teeth are in crossbite. We take a look, and now we're going to restore these teeth. We can see that we've created that bevel on the facial towards the occlusal third. And in the gingival area, because these are very deep, on the 2 premolars, we've created retentive grooves. The enamel margin has a bevel 1/2 to 1 millimeter in length with a 45-degree angle. The cervical has that gingival retention created in the middle of the cervical wall, not against the axial wall, created with a quarter round burr. And then the tooth is restored with an adhesive composite. You've just been viewing and listening to the e-lecture, Decision-Making in Restorative Interventions, Class 5 Cervical Lesions. This was Module A on non-carious cervical lesions. You'll be learning more in Module B about carious lesions that are Class 5s, on decision-making for replacement and repair of these Class 5 lesions, and how we treat dentinal hypersensitivity, Ruth sensitivity.